Good afternoon, everyone. I am Dr. Arun Jindal, Junior Resident in Subharti Medical College in Psychiatry Department. Today, I will be presenting my seminar on depot antipsychotics. My moderator for the seminar is Dr. Swale ma'am. And firstly, the index. In this, firstly will be the introduction, then with the benefits of using long-acting antipsychotics, then general features of depot antipsychotics. After that, individual antipsychotics, and after that, prescribing depot antipsychotics, and practical guidelines to give antipsychotics, then conclusion, and then ongoing research. In the introduction, firstly, schizophrenia is a major psychiatric disorder characterized by psychotic symptoms that will alter the person perception, thoughts, mood, and behavior. Here, antipsychotic medication are the first-line treatment for schizophrenia and other psychotic disorders, in which we are using second-generation antipsychotic as the first-line treatment. Firstly, in the early phase, we have to use the second-generation antipsychotic, and after that, we have to maintain the treatment on antipsychotics. It is also highlighted that benefits of switching patient to a depot antipsychotic. Uh, there are many benefits of shifting the patient to depot antipsychotics as compared to oral antipsychotics. In benefits of long-acting antipsychotic, firstly, non-compliance. Many patients in the schizophrenia are non-compliant to the medication that will result in relapse and hospitalization, and it will result in worsening of the illness. When we are using long-acting antipsychotics, it will be given less frequently and also can be given to the patient who have lack insight and can also prevent the negative clinical outcome and worsening of the illness. Long-acting antipsychotics were associated with reduced hospitalization, emergency admissions relative to the oral antipsychotic in schizophrenia. Many patients in schizophrenia are also overdosing by themselves, so it will also eliminate the risk of overdosing. And in many patients, they are also not willing to take antipsychotic drugs, and it will also avoid this problem. In long-acting antipsychotics, the first pass metabolism is passed, uh, because of which we have many advantages. Firstly, it can increase the bioavailability of the drug that will minimize the side effects, and it will also give a consistent plasma drug concentration. Another possible advantage of long-acting antipsychotic medication is that sometimes it is not clear that this refractory illness is due to non-adherence or it is already a refractory illness. So we have to using long-acting antipsychotics, we can check whether the illness is refractory or it is due to non-adherence. By using long-acting antipsychotics, we can regularly scrutiny of the patient mental state and side effects by the healthcare professional administering the injection. General features of long-acting antipsychotic. These drugs are short-acting compounds. They are released from slowly over a period of several weeks and can take days or weeks to achieve a therapeutic serum concentration and weeks to months to achieve a steady state. Once steady state is achieved, then plasma levels will be stable and like in oral antipsychotics, daily peaks and trough levels are not occurred. Generally, first generation or typical antipsychotic depot preparation are oil based, and it will cause pain at the injection site, while the second generation antipsychotics are aqueous solutions and it will cause less pain. Once injected into a muscle, these formulations form a reservoir and or a depot of the drug that is slowly dissolved in the surrounding blood, where endogenous plasma estesis will hydrolyze the compound and liberate the drug very slowly. Antipsychotic depots do not produce acute movement disorder because it will take many hours or days to achieve its effect. So when we are giving anticholinergic like procyclidine or promethazine, it is illogical to give that combination with long-acting antipsychotics. Uh, there are two types of long-acting antipsychotic: first generation antipsychotic and second generation antipsychotic. In first generation antipsychotics, these are oil-based, which system while they are used, and these agents are fluphenazine diconate, flupentazole diconate, haloperidol diconate. In second generation antipsychotics, these are aqueous solutions, in which if we are using paliperidone palmitate, this suspension is of nanocrystals in aqueous solution. If we are using olanzapine palmate, it is a microcrystalline salt powder of the olanzapine. If we are using risperidone or aripiprazole, these are the microspheres of biodegradable microparticles. This is a development of long-acting antipsychotic. The first antipsychotic to be discovered as long-acting was fluphenazine ethanoate, and after that fluphenazine decanoate, and after that it is haloperidol, and in 2003 risperidone is the first long-acting antipsychotic in second generation, and after that in 2009 to 2010 paliperidone and olanzapine are approved, and in 2013 paliperidone 6 monthly is also approved. Individual long-acting antipsychotics. Firstly, olanzapine long-acting antipsychotic. It is a long-acting injectable formulation of a atypical antipsychotic olanzapine for the maintenance treatment of the schizophrenia. This product is a microcrystalline salt of the olanzapine and a pymoic acid suspended in an aqueous solution. Here the peak plasma levels are achieved within a week. In most people, it will take only 2 to 4 days to achieve its peak. So half-life of this injection is around 30 days, and it is available in 3 doses: 210, 300 and 400 mg, 405 mg. It is also given in the gluteal muscle, and when we are trying to switch the patient from oral to olanzapine long-acting, direct change can be possible because it will only take 2 to 3 days to achieve its maximum effect. But if we are switching from the another long-acting antipsychotic but no risperidone, uh, it can be started on the day it was due, antipsychotic injection was due. When switching from risperidone, olanzapine should be started 2 weeks after the last injection due date, because risperidone peak plasma levels occur after 4 to 6 weeks after the last injection. In olanzapine, it can also cause post-injection syndrome or post-injection delirium syndrome. It can be due to the direct or a partial injection into the vasculature or bleeding around the injection site. That can lead to the direct contact of the olanzapine with the blood. It mimics the olanzapine overdoses, in which patient can have sedation, dizziness, slurred speech, agitation, confusion, ataxia, weakness, or unconsciousness. This incidence is less than 0.1%, and almost in many patients, it will occur in the first hour of the delivery. After each injection, patient should be observed in a healthcare facility for minimum at least 3 hours to check the signs and symptoms of olanzapine overdose. If we are giving the oral antipsychotic, that is olanzapine, in 10 mg per day, then firstly for initiation of the long-acting antipsychotic, we have to give for 8 weeks. If we are using 10 mg per day, we have to start with the 210 mg every 2 weeks, or 405 mg every 4 weeks. And after 8 weeks, we have to maintain the dose, and it will be maintained by 150 mg every 2 weeks or 300 mg every 4 weeks. And the 15 mg is equivalent to the 300 mg every 2 weeks, and after that by maintenance 210 mg every 2 weeks or 405 mg every 4 weeks. And in 20 mg per day, it will be 300 mg every 2 weeks, and for maintenance it will also 300 mg every 2 weeks. The next one is a paliperidone. Paliperidone long-acting injection is a atypical antipsychotic that also contains extended release intramuscular paliperidone palmitate and was also approved FDA approved in 2009. Paliperidone is an active metabolite of risperidone, so its pharmacology and mechanism of action is similar to that of risperidone. Active paliperidone levels are also seen within a few days, and co-administration of oral paliperidone or risperidone during initiation is not required. And medium time to maximum plasma concentration is 13 days. Pre-filled syringes are available in this long-acting preparation, and administration process is also important because before giving the injection, we have to shake this solution very vigorously uh, to evenly distribute the suspension. No test dose is required for paliperidone palmitate, but patients should ideally be currently stabilized or have previously responded to oral paliperidone or risperidone. It is given in two forms. It can be given 1 month monthly, and it can also be given 3 monthly. In monthly injection, the dosage available is 25 mg, 50 mg, 75 mg, 100 mg, and 150 mg. We have to initiate the treatment with 150 mg first dose, and after 8 days, we have to give the second dose of 100 mg. Both the doses should be given in the deltoid muscle because it will achieve less time to achieve its therapeutic concentration. The recommended maintenance dose is 75 mg monthly, and it can be range from 25 mg to 150 mg depending on the individual tolerability and efficacy. So in this chart, we during initiation on day 1, we have to give 150 mg intramuscular injection in deltoid only, and after day 8, we can use 100 mg intramuscular injection deltoid only, and for maintenance, monthly injection will be 50 to 150 range. 150 mg in age, that can be given deltoid or gluteal region. In 3 monthly, if the patient is already stable on monthly injections for more than 4 months or more than 4 months, the dose of paliperidone long-acting injection can be started. The dose of long paliperidone 3 monthly can be calculated by this chart. If we are giving 50 mg as a monthly, then we have to give 175. If it is 75, then we have to give 263. If it is 100, we have to give 350, and if it is 150, we have to give 525 3 monthly. Risperidone long-acting injection. First atypical drug to be made available as a depot or a long-acting injection. A long-acting formulation is prepared by encapsulating the risperidone into biodegradable polymeric microspheres using PLGA. It is a copolymer of glycolic acid and lactic acid. This PLGA microsphere delivery agent is used in many therapeutic agents like naltrexone. It is available as risperidone consta in a dosage of 25, 37.5 and 50 mg. The main release of the drug starts 3 weeks after the injection, and it is maintained for 4 to 6 weeks, and its effect is subsided by 7th week, and steady state is reached after 4 injections. So if we are giving the risperidone orally for 2 mg and we have to take it to the effective dose, if tolerated, prescribe equivalent dose of long acting with oral risperidone for at least 3 weeks is to be given, and then taper over 1 to 2 weeks. Doses of 25 to 50 mg every 2 weeks appear to be as effective as 2 to 6 mg per day of risperidone. In the event of discontinuation, it needs to be taken into the account that risperidone level will maintain for at least 3 weeks after the last injection. The maximum dosage is 50 mg every 2 weeks. In the old age, we can give 25 mg every 2 weeks. Prolactin levels appear to be reduced somewhat following a switch from oral to injectable risperidone. Those patients who are stabilized on 2 mg per day, we have to start him on 25 mg for 2 weeks, and those who are on higher doses, we have to start on 37.5 mg and slowly increase to 50 mg 2 weeks. Equivalent dosage of risperidone as compared to paliperidone. If we are giving risperidone oral tablet, then long acting will be 25 mg, and if we are giving risperidone 3 mg, it will be 37.5 mg, and if we are giving 4 mg risperidone, it will be 50 mg. And if we are giving as compared to paliperidone, it is double the dose of the risperidone. If we are giving orally 2 mg, it will be 4 mg, and in the long acting, it will be 50 mg. If the risperidone is 3 mg orally, then it will be 6 mg orally paliperidone and 75 mg long acting injection of paliperidone. If it is 4 mg risperidone, then 9 mg paliperidone is to be given, and 100 mg is a long acting injection. If risperidone is 6 mg, then 12 mg is the paliperidone dose, and 150 mg is the long acting dose. Aripiprazole long acting injections. It is a extended release injectable suspension available in 400 mg or 300 mg strength vials and approved for schizophrenia in 2013. As we know, aripiprazole lacks the many adverse effects like metabolic adverse effect or prolactin related adverse effect. It is also given monthly, and oral aripiprazole 10 mg per day for 14 days is recommended initially to establish tolerability and response. One injection start therapy is during the initiation, we have to give the injection of 400 mg aripiprazole along with the 20 mg oral aripiprazole for 14 consecutive days. Firstly, we have to give the patient 20 mg orally for 14 days to check the tolerability. After that, we have to give the 400 mg injection with 2 mg oral aripiprazole, and then oral will be continued for 14 days, and it will total take 28 days to maintain healthy dose. And after that, we have to give the aripiprazole monthly. In 2 injections start, we have to give the 2 injections of 400 mg aripiprazole along with the 20 mg of oral dose, and after this oral therapy will be discontinued, and after that only monthly doses will be given to the patient. A lower dose of 300 mg a month can be used in those who are not tolerating 400 mg. A dose of 200 mg a month may be used if the patient is taking enzyme inhibiting drugs. The incidence of akathisia, insomnia, nausea, and restlessness is similar to that seen with oral aripiprazole. It is the cost of long-acting injections available in India. Risperidone 2 ml will be cost up to 5100 to 6500, and Olanzapine will be cost up to 1000 to 1300, and Paliperidone available in India is 150 mg of 2200, and Aripiprazole is not available in India, and its cost will be $456. This one is the first generation antipsychotic that is long acting. Haloperidol decanoate is an ester of haloperidol and decanoic acid dissolved in a sesame seed oil. After intramuscular injection, haloperidol decanoate is gradually released from the muscle tissue and hydrolyzed slowly into free haloperidol, which enters the systemic circulation. Haloperidol decanoate is an potent dopamine antagonist. It is available as a brand name injection Sinorum long-acting 50 mg per ml or injection Trancodol 50 mg per ml, and its cost will be 180 to 200 for per ampule. Peak plasma levels are seen up to 7 days after intramuscular injection. Plasma half-life is around 3 weeks, and steady plasma concentration can be expected to be reached after 2 to 3 months of regular dosing. While switching from oral to depot dose, it can be calculated as 15 to 20 times the oral dose and is to be given for 4-week interval. Maximum dose will be 300 monthly, and there is a high risk of EPSC and tardive dyskinesia. Flupentazole. Long-acting injection is formulated as flupentazole decanoate in a low viscosity vegetable oil. Peak plasma level uh, occurs in 3 to 7 days after intramuscular injection with apparent half-life of 17 days. Steady state plasma level can be expected to reach after 2 to months of regular dosing. It is available as an injection Spenzo, that is 20 mg per ml and 40 mg per 2 ml. Cost will be around 100 to 200 for 20 mg ampule. Initially, the test dose of 20 mg should be given if the patient is tolerating this dose, and after 1 week we can increase it to 20 or 40 mg. Maintenance dose of flupentazole will be 20 to 40 mg, and it have to be given every 2 to 4 weeks. Depot dosage is 8 times the oral dose. Fluphenazine. Piperazine phenothiazine compound. It is a piperazine phenothiazine compound. Fluphenazine deconate is available as a long-acting injectable in sesame oil. Plasma levels peak within 24 hours of intramuscular injection. Half-life is approximately 7 to 14 days, and most patients are successfully maintained within the dose range 12.5 to 100 mg, given at a dose interval of 2 to 5 weeks. Plasma level obtained vary up to 40-fold in patients receiving the same dose. Smoking significantly reduces the plasma fluphenazine levels. Penfluridone. It is an alternative to long-acting injectables. It is an oral depot form because it has a very long half-life, that is 60 hours, and is also available in India. The long duration of action seems to be a result of the rapid distribution in the fat tissue that will act as a drug reservoir. It is used once in a weekly oral tablet and to be given under supervision. Dosage will be 20 to 40 mg a week, and its efficacy is as compared to the first generation depot antipsychotics, and the side effects are also similar with the first generation antipsychotic, and it will also cause QT prolongation, and minimal sedation is there with this drug. This one is a chart for first generation antipsychotic that are used as a depot forms. For haloperidol deconate, starting dose will be 50 mg, and the maintenance dose will be 50 to 200 mg every 3 to 4 weeks. For fluphenazine, starting dose will be 12.5 mg, and maintenance dose is 12.5 to 50 mg every 2 to 3 weeks. For flupentazole, starting dose will be 20 mg, and the maintenance dose is 50 to 300 every 2 to 4 weeks. Zoclopentazole decanoate, starting dose will be 100 mg, and maintenance dose is 200 to 400 mg every 1 to 4 weeks. This one is a chart for second generation depot injections. For Olanzapine, it is given in gluteal region, and tested dose is not required, and have to be given 150 mg every 2 weeks or 300 mg every month. And the dose interval dosage is 2 to 4 weeks, and it will also cause post injection syndrome risk. Paliperidone palmitate, it will be given, first dose will be given in the deltoid, and after that deltoid or gluteal region can be given. No test dose is required, and 50 to 150 mg is given monthly, and 175 to 575 mg is to be given 3 monthly, and here the loading dose is required. Risperidone microspheres, it will be given deltoid or gluteal injection, tested dose not required, and it will be given in a dose range of 25 to 50 mg every 2 weeks. Here oral therapy is also required because of the delayed response. Aripiprazole to be given in the gluteal region, and tested dose is not required, and it will be given 300 to 400 mg monthly, and it will have less side effects. Advice on prescribing long-acting antipsychotic. For the using the first generation antipsychotic depot injection, we have to give the test dose. Because of its long half-life, any adverse effect that results from the administration of an long-acting antipsychotic medication are likely to be long-lived, and it will also serve a dual purpose by checking the patient's sensitivity to EPSC or any sensitivity to the base oil. Not required for second generation antipsychotic. It should be given when patient is antipsychotic naive. Administered at the longest possible license interval because it will cause more discomfort and pain when giving very frequently. Adjust dosing only after an adequate period of assessment because attainment of the peak plasma level, therapeutic effect, steady state plasma levels are all delayed with the long acting injection compared with the oral medication. It should be begin with the very lowest effective dose. In most long acting injectables, plasma drug level increase over several weeks to months without any increase in the dosage, and steady state is only achieved after 6 to 8 weeks. Dose increase during this initial period is also illogical. Long-acting injections are not recommended for those who are antipsychotic naive. Tolerability to some long-acting antipsychotic medication can be established by using oral form of the same drug for 2 weeks before starting. Practical guidance to administer long-acting antipsychotic. Length of the needle should be minimum 1.5 inches. Sterilize the skin before the injection, and Z technique is used in which we have to place the thumb on the skin and a shearing stress is applied over the skin, and that will slide the skin and the subcutaneous tissue to expose the underlying muscle, and then inject through displaced skin with with a smooth action. If any resistance is felt, probably it indicates the ileum, so needle should be withdrawn half an inch to 1 inch before depressing the plunger. As with oily injections, it is important to ensure by aspiration before injection that inadvertent intravascular injection does not occur. Injection should be altered between two sites every time giving injection. Only risperidone depot injection requires cold chain. Conclusion: depot preparation is an important tool in the management of schizophrenia. Its usage is limited because of the perception among psychiatrists that depot preparation should be used only when there are multiple relapses. There is an evidence to show that outcomes are favorable and the risk of hospitalization and relapse is reduced when depot preparation is used in early stages of schizophrenia. The cost of the considered second generation depot preparation can be limiting factor, but if we cost of oral pills for 1 month to depot along with the long-term risk of relapse, it may seem less expensive treatment. The utilization of the long antipsychotic in first episode schizophrenia is to prevent a cognitive decline induced by demyelination. Treating with a long-acting antipsychotic as early as possible, ideally from the first episode, can reduce relapse, number and duration of rehospitalization, and cognitive symptoms, and improve the quality of life and functional outcomes. Ongoing research clearly head-to-head comparison studies between two or more long-acting injectables are critically needed to clarify the role of each compound in the long-term management of the psychotic disorders. These are the references. Thank you.